if you have osteoarthritis or know someone who also has this, or maybe you're a clinician who takes care of patients with osteoarthritis, then this will be helpful for you. We're talking all about osteoarthritis. Let's get started. Thanks so much for stopping by today. I really appreciate it. My name is Jordan Rennicke, and this is the Building Lifelong Athletes podcast. The goal of this podcast is to help keep you active and healthy for life through actionable, evidence-informed education. Thanks so much. I really appreciate you tuning in. Today, we're talking all about osteoarthritis. So we're going to talk about what it is, how we diagnose it, what does it mean, how do we treat it. So we're going to dive into all the specifics of osteoarthritis. So let's get started. All right, so first things first, let's talk about why we care about this, right? So let's talk about the incidence and kind of the cost to our society. So overall, there's about 30.8 million adults in the US who have this. So that's just the US, and about 300 million people worldwide who have arthritis. So that is super common. 300 million people. That is a lot of people. So we see this all over the place. Worldwide, estimates that about 9.6% of men and 18% of women over the age of 60 have symptomatic OA. So not necessarily, X-ray findings, like symptomatic mean they have issues with it. And it is the leading cause of disability in older adults. And overall, it's estimated to cost us society about $303 billion yearly. Billion. If you've ever worked in primary care, this is everywhere, right? There's lots of people who have arthritis, very common, costs a lot of money, and it's debilitating. And the reason we care so much about arthritis specifically is because what it loses for people, right? They lose their ability to do the things they love. And that's why we care about it so much. And that's like the biggest thing for me as a sports doc is like, all right, I care about this because it's preventing people from doing things they want to do. Whether that is, running in triathlons. I've seen Ironmen in here with arthritis, or if it's someone who's like, hey, I want to be able to play on the ground with my kids. Like I see it a lot. And so that's what worries me. And so that's the big thing. And moving on here, let's talk real quick about pathology. So it used to be thought of as kind of a wear and tear diagnosis, right? So it used to be that, hey, it was all like over your altered biomechanics and overload. Like that was the thing is like, hey, this is wear and tear. You did this, you ran this way. and that doesn't seem to be very correct. There's lots of information that's involved and metabolic factors that play a role and make it just much more complicated, right? So everyone used to be like, oh, like you did this, you ran a lot, you did this, that caused it. And that just does not seem to be the case at all. Overall, they say that for the definition wise, there are certain structures that are affected, right? So by definition, the articular cartilage is affected. And when I talk about articular cartilage, I'm talking about like the smooth cartilage on the end of the bones that helps with decreasing friction and transmitting forces. So if you think of we'll say like glenohumeral joint or the hip joint, right? We have the ball and socket. The articular cartilage is going to be that outside lining of both, we'll say for the shoulder, the glenoid and the humerus. They have both sides have articular cartilage that kind of helps it just glide in a more frictionless environment and kind of protects it there. However, though, we're learning that arthritis is not just an issue with the cartilage. It is a whole joint process, meaning that the synovium or the fluid around there, the joint capsule itself, the ligaments, the subchondral bone or the bone beneath the articular cartilage is also having issues. And so that's a big thing. When we're talking about an entire bone process, this is all the things it can be. The synovium, ligaments, it's not just cartilage. So it's cartilage, it's the bone underneath the cartilage. It's essentially a joint disease. I've heard some people say it's essentially a whole joint process. Now it's no longer just your cartilage. It's almost like a joint failure, not full joint failure, but we talk about heart failure where it's not like, oh, your heart isn't failing. It's just not doing its job. I've heard some people talk about that. I don't know how I feel about that, but it's overall, it's much more important than just saying just the cartilage. There's a lot going on. And overall, once again, there's lots of inflammation that's seen in there. Inflammation is seen in all cases of osteoarthritis, and it's unclear how it starts, right? Whether it's like, oh, we have some issues with the cartilage that creates inflammation, or is it inflammation that creates the degradation of the cartilage? Not entirely sure, but inflammation definitely plays a role. And it's very clear that there's definitely something going on there. And so moving on from pathology, let's talk about the different risk factors. So as you can see here on the screen, there's a whole bunch of risk factors going on. And specifically, age is the single greatest risk factor, right? So unfortunately, as you age, your risk of developing osteoarthritis increases. That seems to be the greatest, risk factor that we have. But there's also a bunch of other risk factors. Some things we talk about are genetics. So genetics are a polygenic risk, so not monogenic. Monogenic means, hey, you have the arthritis gene, and that doesn't seem to exist. Polygenic means it's probably multifactorial. Interestingly enough, obesity and metabolic syndrome seems to have a very strong correlation with development of arthritis. There's an odds ratio of about 2.96 of having OA in those who are overweight or obese. So you're essentially doubling your chance of having that by having overweight or obesity. And I think that goes in with that, hey, we understand that having excess adipose tissue is not inert, right? We used to think adipose tissue is inert. It just kind of sat there, but no, we know it's very active, like metabolically and in terms of hormones it releases. So having excess adiposity does not seem to be beneficial and increases your risk of having any sort of osteoarthritis. And also people with increased risk to have low levels of vitamin C or D might increase risk for that. It seems to be more prevalent in women than men. Previous injury, very common. We know that previous damage to the joint increases the risk of developing osteoarthritis. And we've seen this time and time again with people, they have an ACL injury, right? They tear their ACL completely, and the odds of them developing arthritis later in life is much higher and actually develops pretty early. So previous trauma seems to play an impact on it as well. There's some data that maybe your occupation might play a role, meaning excessive kneeling, squatting, jumping. It might increase risk. It's not slam dunk on that, but that may be. And then also sports, those who play competitive sports may have an increased risk. And we talk about, you shouldn't, would you not do sports? Like, no, you should do sports. Sports are awesome. They're the best. Hopefully we're lifelong athletes, right? That's the goal, is to keep everybody healthy for life. But those people who play are at an increased risk of having those injuries, right? So if you're playing competitive sports, then you have a high risk of having some sort of knee injury, whether it's a meniscal injury or an ACL injury. Like, that seems to be the correlation where, like, hey, you have a high risk of injuring your knee, so therefore arthritis, as opposed to just like, hey, the sport you do creates it, which is not necessarily the case. But I've talked about this many times, that if you are seeing people who are elite athletes, or you're an elite athlete, you're having that trade-off, right? Like, that's not the healthiest thing in the world. Like, those people who play high level anything, they're not the healthiest people in the world. They're obsessed with their sport and they're pushing their body to the limits, and it's probably not ideal for overall health. So it's just kind of the trade-off we have. And looking at this kind of picture here, it shows some different type of risk factors. We have non-modifiable risk factors on the right here, like age, gender, genetics, ethnicity. Unfortunately, the cards you've been dealt are cards you've been dealt, but that can be, a large component as well. And there's also things that you have systemic risk factors like obesity or bone metabolism. We also have, potentially dietary intake might play a role, and then local risk factors in terms of like, hey, your physical activity, maybe you had an injury or occupation, different things like that. There are mechanical things as well. And I don't want to be a little, I say like, oh, it's not mechanical. If you have like some sort of like gross joint misalignment or bone length discrepancy, like that can definitely lead to arthritis. And so I'm not saying it can't in like the biomedical model that like, hey, it's just this wear and tear. So that can play a role, but it doesn't necessarily, it's not the only thing, that's for sure. And so moving on from risk factors, let's talk about the symptoms. So what are the symptoms? Pain is the most common symptom, at least shocking news of the day, right? There's typically about two different types of pain, kind of this like dull background pain and intermittent intense pain. And this kind of like is how I think about it. A lot of times you see this presentation of, hey, like my knee's acting up again. People have a known background of arthritis, kind of this dull backgroundy pain. And every once in a while they get these flares, right? Just saw a patient today who just kind of has known arthritis and all of a sudden, whoops, has a flare. And these kind of happen. Usually they're kind of associated with some sort of, increase in activity or whatnot. But that can happen as well, where they have this dull background and then intense flares. And usually this unfortunately increases over time, right? Like early, like you can identify the triggers. Like, oh, like I ran and, usually when I run over X amount of miles, it flares up and that's identifiable. Then later it kind of increases in consistency, meaning like you're having pain more consistently. It's not just with activity, it's kind of increasing. And that's kind of the progression of arthritis, unfortunately. However, one thing to mention is that pain does not correlate with imaging finding, right? So like, I just want to emphasize that again. It's like pain does not correlate with the image findings. That's like the big take home. Like you will see all the time, I've seen this, it's incredible. I saw a gentleman in my fellowship who's probably in his 80s and just had, quote unquote, bone on bone arthritis, right? He's like, oh, my knees kind of hurt a little bit. And that's like literally his only complaint is like, my knees are a little sore. And you see the x-rays and you're like, oh my gosh, like that's incredible. So it does not correlate necessarily. You'll see people who have pristine looking knees and they have knee pain, or people who have bone on bone arthritis and they don't really have pain. So pain does not necessarily correlate with imaging findings. Additional symptoms, people may have swelling, clicking, locking, crepitus, reduced range of motion, and maybe a visual deformity. Like they might have their legs kind of bowing out. Potentially that's one thing. Reduced range of motion, a lot of times they'll have trouble getting into deep flexion of that knee just because they might have swelling in the knee, and that might be causing the reduced range of motion. Also might see some morning stiffness. Usually it's less than 30 minutes though, right? So we think about if it's greater than 30 minutes to an hour, we start thinking about like systemic stuff like rheumatoid arthritis potentially, something like that. But just kind of 30 minutes, that's kind of the big thing. And overall, the most important thing that I mentioned here is the biggest symptom is that impairment of their activities, right? This is what people want to do. It limits what they want to do. I want to go running. I want to do this. I want to be active. And that's why we care so much about this. And the symptoms are so important because we want to make sure that they're doing okay, right? We want to get them back to doing the things they love. So that was the symptoms. Let's talk about the exam, right? Overall, this is just a general arthritis talk, but the majority of arthritis you're going to see is typically like in the knees, hips, and then some of the hands. So like CMC, carpal metacarpal joint, or the DIP joint, maybe the MTP of the foot as well. And then also spine, which we're not really talking about spine too much here, but those are like the most common ones. You can have it anywhere, right? You can have anywhere you got a joint, you can do it. I've seen an elbow. A lot of times it's post-traumatic, but it can be anywhere. But a lot of times knee is the big one we're talking about. And you might have joint line tenderness, meaning when you're palpating in that specific joint, specifically on the knee, you might have pain there. Patients might have reduced active and passive range of motion. Specifically, like let's take hip example, right? If you have hip arthritis, a lot of times you are really limited range of motion. Or like shoulder arthritis, they really just globally are reduced in their range of motion. So if you're missing range of motion with pain, maybe think about arthritis. You might have crepitus, so when you feel their hand on like their shoulder or knee, you kind of feel some clicks and pops. I would say it's like Rice Krispies going on there. You might feel that. They may have an effusion or swelling, so in the knee that's able to appreciate that. A lot of times you'll be able to feel the knee and say like, hey, that's deformed, meaning, hey, we have either an effusion there, or it's you're missing the contours. A lot of times what I look at it for the knee specifically is you can see that patella, but then if like it's swollen, you can't really see the landmarks of the knee. That might be a giveaway. And you may also have just deformities as well, more specifically hands, like the Heberden or Bouchard's nodes, which essentially Heberden is swelling at the distal interphalangeal joints, and the Bouchard's nodes are the proximal. So think about distal and proximal. So distal ones are going to be Heberden, and proximal is going to be Bouchard. So we're here, kind of just these nodules is what you look at. So overall, obviously it depends on the joint they're coming in with, but you can see the general pattern is that you're going to have pain there when you palpate, and then you have decreased range of motion, plus or minus swelling are the big things we look at. And when we're looking at additional things, we're looking at imaging here. Well, this helps confirm the diagnosis, which is mostly clinical. You typically, if you have pain, you can't just be like, yeah, you got arthritis, I can feel it. I mean, you can probably guess if someone's like coming in their 60s or 70s and they have pain and it seems to kind of fit that picture. Like you can be like, this is probably arthritis. But X-rays are going to be helpful to kind of confirm that. X-rays are typically all that are needed. We don't need to go into any additional imaging. In X-rays, some findings that we find are things like joint space narrowing. So if you think about, right, we have our bones here and our knee normally, and they're just closer together. That's joint space narrowing. You may also find osteophyte formations. We're looking here. Osteophytes are kind of these branch offs here. They're kind of just outpouching of additional bone. We see that all the time in there. And then things we can also talk about are subchondral sclerosis. So when I think about thickening the bone, if you look in this image here, you can see a little bit here. There's this bright white on this side of the DIP, and then this side of the other joint as well. So this kind of thickening of the bone underneath the joint is kind of where we think of subchondral sclerosis. You may also see cysts as well. And when we're talking about the knee, typically we want to get is weight bearing. I recommend getting weight bearing for pretty much all things. I think for foot, knee, hip, anything lower extremity, I want to get weight bearing because that's when patients are most symptomatic, right? Is weight bearing. And so for knee specifically, weight bearing, and then the AP, so front and back, and then lateral are typically all that are needed. But a lot of times we'll order the sunrise as well, which is where someone's squatting. You can look right down the patella. And you can kind of look at the patellofemoral joint, which is helpful to get a better look at the actual inside of the joint there, patellofemoral joint. So those are the ones that I'll typically order. And when you do that, it kind of classifies it into this Kellgren-Lawrence classification. So this is kind of how we're diagnosing things. And it's the most common classification system for osteoarthritis. So this classification can be used at any joint. So it doesn't necessarily have to be like the knee, but can use it for the hip and whatnot. But a lot of times it's just classifying how bad is the arthritis from a radiographic standpoint, right? So we got to remember, the Kellgren-Lawrence classification is good, and it shows us what's it's helpful for, shows us how much radiographically is going on, but does not tell us what the patient's symptoms are going to be, and we can't correlate with that specifically. But grade 0, meaning, hey, looks good here. We have no joint space narrowing or reactive changes at all. Grade 1 is doubtful joint space, meaning doesn't really look like it's narrowing. Maybe some osteophytes kind of going on there, but looking pretty good. Grade 2 is definitive osteophytes, like we talked about, kind of outpouching of additional bone, or definitive joint space narrowing, and then possible bone end deformity, like we talked about with that sclerosis. And then grade 4 is large osteophytes, marked joint space narrowing, severe sclerosis, and definite bone and end deformity, meaning, hey, we're seeing a lot of stuff going on. So this KL3 arthritis is what they'll typically say, and that can be helpful for research purposes. Overall, you see these and say, okay, like what does that mean? It's grading, which is helpful for potential research and treatment options, meaning some treatment options are better for lower grade versus higher. But once again, this is very fluid in that, like, okay, if someone has grade 3 but minor symptoms, okay, great. I have the diagnosis and that's fantastic, but you're treating the person, not necessarily the radiographs. So there's just something to consider as well. MRI, people love getting MRIs. They'll ask you, say, hey, like, I need to get an MRI, overall can help give more detail, but definitely not always needed. In the situations that may be helpful is, hey, if we're looking for early arthritis, right, and we're looking for the integrity of the cartilage, it can help determine the possibility of, underlying etiologies. So like, hey, like this doesn't make sense. What's going on? We find a meniscus or an ACL tear, or maybe it's a young person who's done a lot of stuff and not getting better. You get an MRI and see, there's actually some early arthritis forming in there. That can be helpful because there's different procedures and interventions that can be done. But overall, run of the mill, if you're just like, hey, you have these symptoms and the X-ray shows arthritis, like an MRI isn't going to tell you more, because a lot of times, specifically, we'll talk about the knee for just 1 second. Patients will come in and say, hey, I think I need an MRI for my knee. Like, I think something's going on, they have known arthritis, right? So known arthritis, and they want an MRI. And the reason a lot of times, one, it won't be covered by insurance necessarily because it's not indicated for arthritis. And two, it's not really going to change management, because hear me out. What's going to happen a lot of times is, for the knee, you're going to get an MRI and it's going to show some degenerative changes of the meniscus. Like, that's guaranteed. That's pretty much by definition, working through the cartilage and the meniscus, like you're going to see that. And the question is, what do we do with it? Well, a lot of times we're not sending off to surgery and we just kind of rehab it anyways. And so it's wasting patients' time, which MRIs take a while. It's wasting their money because it's not going to change our plans. And so there is a time and place for MRI. That is not your first imaging unless there's some sort of trauma, which we've detailed in other lectures. But additionally, we just start off with x-rays and then kind of work our way to MRI if things aren't making sense. And then we can use ultrasound occasionally looking for inflammation and bony hypertrophy. A lot of times for the knee, you can see an effusion. You can see in the fingers, specifically, you might see some hypertrophy or some additional swelling. I was just looking at a patient today with CMC arthritis and saw some swelling there. So you can use ultrasound, which can be very helpful as well. And if you think about looking at those things, overall x-ray first, plus or minus MRI, and then ultrasound, I would put that above MRI just because of ease of use. Not everybody can do that and has that skill set, and that's okay. But if you have that, that's going to be cheaper, no radiation, and that can be really helpful as well. So that's kind of our general imaging here that we talked about. And let's move on from there. Let's go to our labs. So looking at our labs, usually the labs in these patients are normal. A lot of times you might want to think about getting a CRP or an ESR, which may be useful to help rule out some systemic conditions like autoimmune conditions or other inflammation or infection, anything like that. And maybe you want to get a uric acid to kind of look in for gout as well. But overall, labs shouldn't be crazy for a patient who has just run-of-the-mill osteoarthritis. And then finally, we've kind of talked about all this, and let's talk about our treatment. And unfortunately, there's no cure for osteoarthritis. That's like the biggest bummer of the day. It's like, oh, do we have a cure yet? No, we don't. Treatments are kind of just treating symptoms. They're broadly classified into reduction of modifiable risk factors, intra-articular therapy, physical modalities, alternative therapies, and surgical treatment. So we're kind of walking in here. First things first is modifiable risk factors, right? So obesity is probably the biggest one. There's a study that demonstrated that the risk of symptomatic knee OA in women decreased by 50% by losing 5 kilograms of weight. So 50%, 5 kilograms of weight. You think about, the way you do the quick math is 5 times 2.2, so randomly 2. So you're looking at like 12-ish pounds here, something like that. Losing 12 pounds can decrease symptoms by 50%. That's huge. And so they've also shown that in those studies that there's structural improvement of the cartilage and positive changes in biomarkers of the cartilage and bone with weight loss. So really, when we say this, it's not a matter of just like, hey, mechanically, like you're taking stress off your knees, which is true biomechanically, but it also seems to be changing the hormonal milieu of the actual joint itself. And so we're getting to this point now where like obesity and arthritis are so related that like we should probably be treating arthritis by managing obesity. Obviously in primary care, there's lots of good ways to do that now with medications. Obviously lifestyle is going to be first. Everyone talks about lifestyle first, but it's just something we have to start talking about with patients. And also, with patients, if you're listening to this, I think it's important to understand that, hey, like it's an uncomfortable conversation, but it has to be had because it's very important. And we'd be doing a disservice if we didn't talk about that. So that is like the first thing first, like we should consider and look at. And exercise going hand in hand as well. A Cochrane review shows, with knee arthritis, that those who had exercise had a decreased pain, improved physical function, and mildly improved quality of life. And so the improvement was noted. It was similar to those previous studies evaluating NSAIDs. So essentially, okay, exercise can provide as much quality of life and pain improvement than taking non-steroidal anti-inflammatories, things like ibuprofen or naproxen, which is pretty substantial, right? People say they take that all the time and to help improve their pain. If we can do that with exercise, we're getting pretty much all the benefits and none of the risks of NSAIDs or anything like that. So that's great. And then physical modalities, they talk about unloader braces. They may or may not be helpful depending on the side. And for patellofemoral way, maybe a sleeve with a patella strap. So when I mean unloader braces, what we think of is, we have the knee here specifically, is these braces kind of distribute the forces of the knees a little bit differently. So if you have like really bad medial joint line issue, it kind of offloads that potentially. That's one thing. It's kind of hit or miss. The data doesn't seem to be like definitive, like, yeah, you should get that, but something you can consider. And then for patellofemoral way, it's more of like a patellar strap, meaning, or like a sleeve. So like kind of one of those pull-up sleeves. You see like the Copper Fits, not the Copper Fit specifically. And it's not a name brand thing, but you'll see a lot of times people talking about those. Oh, I want to get that. Sleeve may be helpful, but it's not necessarily slam dunk there. Some additional alternative therapies. People talk about acupuncture that may be helpful. Data is kind of mixed on there. Self-management education, this is actually very interesting that patients' perception of this can be very, very important. That they found that those people who had negative self-thoughts, maybe were struggling with depression or anxiety, or had pain catastrophizing or social isolation, those had worse outcomes. So people who were isolated, worse outcomes. People who like thought that any sort of pain was like a big catastrophe, meaning like, oh my gosh, this is scary, this is bad, this is painful, I can't have this. Like pain catastrophizing is that, and that leads to worse outcomes. And unfortunately, comorbid depression, anxiety also plays a role. And so educating patients on, hey, we're going to have flares, right? We're going to have pain. That's unfortunately how this disease presents, but how do we manage those things, right? Are we locked in with our lifestyle? Are we sleeping well, right? Sleep, we know, can play a big factor. Are we eating well? Are we maintaining a healthy body weight? Are we exercising? All the things we can do, control those, understanding, hey, we'll have some good days and bad days, but educating patients on that all pain doesn't necessarily mean like you're wearing your joint out worse. So just understand that can be helpful. From a medication perspective, NSAIDs do improve pain from OA, but come with lots of side effects, right? Our stomach, kidney, heart, people with heart disease, we don't typically want them on NSAIDs. If you have a kidney disease or stomach ulcers, don't want them on there. So it's also, we want to avoid those if possible, but obviously you need to use them judiciously. Acetaminophen can also be helpful, but not quite as much as NSAIDs. So that's probably the safer of the two, just because it does get processed by the liver. Say, if someone has liver issues, obviously probably want to hold off on that. But a lot of times kind of acetaminophen as the base and NSAIDs as breakthrough. Other medications like duloxetine, which is an SNRI, may be helpful. And then supplement-wise, people talk about all the time like glucosamine, chondroitin, kind of mixed results there. It's one of those ones where you have to have a discussion with the patient, right? Like, hey, is this worth it? Do we want to take this supplement that we don't necessarily know if it's effective and it's costing you money? Like if patients like, well, I like burning money and I'm cool with that, then that's fine. And they can do that, but understand that it's not necessarily like a slam dunk, like, hey, this is going to work. From an intra-articular treatment perspective, we talk about going inside there. Steroids, we do injections all the time, but they're short-term and chondrotoxic. So we're trying to move away from that. I reserve those usually for flares. So that's like the big thing. Patient understands like, hey, they're in a really bad flare. Like, I need to get out of that. Okay, we can do a short term. We do a steroid that kind of helps bring it down, but it's not ideal. And the more you do, it seems to be additive, meaning the more steroids you do, the more chondrotoxic it is, the faster it wears down the rest of the cartilage in the joint. So we try to be careful with those. There are other ones, hyaluronic acid, which is essentially viscosupplementation, was it falls into. This can be used for arthritis best in mild or moderate. Can be used in multiple joints. I've done it in hips. I've done it in knees predominantly, but can be done there. And usually mild to moderate works best. It doesn't seem to be fantastic in late stage arthritis, but can also be done. It's a pretty safe injection, not chondrotoxic. There's some data on prolotherapy or dextrose prolotherapy, specifically with sugar, that may be helpful and also a very safe injection. And then PRP, there's an increasing amount of data suggesting it may be helpful. However, it is incredibly expensive, looking at like over $1,000 a lot of times for this. Mixed data, it's not guaranteed it's going to work for you. Also, platelet concentration seems to be a factor as well, and it's hard to know who has what platelet concentration. It seems to be safe though, and that's the good thing. And it's safe. It's using your own blood, right? So you take out blood from your vein, you spin it down in a centrifuge, and you get concentrated platelets. Inject those back in. It seems to be beneficial, on the whole for arthritis. Is it better than anything specifically that I mentioned previously? That's debatable, but a safe injection that can try. But it's very expensive, so it's not something I recommend right away. And then finally, we talk about surgery, right? So surgery, total joint arthroplasty is the gold standard. We use this in patients who fail to respond to treatment or have a really poor quality of life. So this is something I always mention. A lot of times we like to kick the can down the road and say like, don't ever get a knee replacement or don't think about it. And yeah, we want to avoid that if possible, just because when you have a surgery, you don't know what's going to happen here. You're going to have trouble with anesthesia. Are you going to have, even worse pain after? Is it going to be, the hardware going to fail? There's lots of things that can happen. Our surgeons do a fantastic job of in general of getting really good results, but there's always a risk to that. And so But I think we also do a disservice in primary care a lot of times of not having patients meet with a surgeon early enough, meaning like they can talk with them. They're not guaranteed. I always tell patients like, hey, you're in the driver's seat. Like you decide when you want to have a knee replacement. Nobody's going to look at your x-rays or you and say like, well, it's time, we got to do this, but if you're functionally doing well, like nobody's going to say you have to do it. So it's worth meeting earlier rather than later just to have that discussion and understanding that, hey, if we do a steroid injection, then that kind of buys them 3 months where they're not going to do a replacement. There's an increased risk of infection after doing a steroid injection. And so we don't want to do it. And then they won't be able to do surgery for 3 months because they have to wait for it to kind of clear out and wash out to decrease that risk. So, but making a referral earlier rather than later is reasonable because they can just talk to them, right? Have a discussion with them, say, hey, what does it look like? But that's something to think about. Usually it's when you've kind of failed to respond to the rest of treatment and having a poor quality of life. That's when I consider having a referral for them. When they do the procedure, usually they're up and walking very shortly after. For hips, it's like crazy fast. It's unbelievable. But usually it's still pretty painful. You need to have a multimodal pain approach, meaning usually they get a nerve block before the procedure. They're taking kind of a base layer of acetaminophen or Tylenol. They take opioids, unfortunately. That can be obviously a slippery slope, but necessary when you have a big surgery. And you're going to need extensive therapy afterwards. And overall, total hips seem to improvement in about 6 months, and whereas knees may take up to 12 months. So like the max improvement you'll get from a hip, usually about 6 months, you're like, all right, I'm feeling good. This is what I'm gonna get. Whereas knees, it might take out to 12. So that's a pretty long recovery. And so there's lots of different options that we have for arthritis. Unfortunately, nothing fixes it. And so in summary, arthritis, you're going to think about this when you have patients who are having kind of insidious knee pain. Maybe it's flaring, maybe loss of range of motion. You might have some joint line tenderness on exam. You get x-rays and you show degenerative changes. The KL score we've talked about. It's the imaging plus clinical, putting those together. That's how we make the diagnosis. And treatment-wise, then kind of focus on symptom management. Education is very important. Staying physically active, very good. Working on metabolic factors in terms of body weight, adipose tissue, decreasing weight can be very helpful as well. And then we also have some specific injections that may be helpful, and long-term surgery may be needed. But it's something that we see all the time. It's very common. Unfortunately, managing it can be challenging and it can be debilitating. But the key is to kind of help symptom management so that patients can do what they want to do when they want to do it. That's like the ultimate goal, and then kind of helping them, guiding them and deciding, hey, where do we go from here? But overall, I hope you found this was helpful. This is a very common thing, but yeah, like I said, I hope you found this to be helpful. If you did, I'd really appreciate it if you gave a liked up or share this with someone, right? Share this with a friend who may be suffering with this or a clinician. That'd be very helpful. But either way, I appreciate you tuning in. Now get off your phone and we'll see you next time.